Today I'm going to present my study titled Predictors of Hepatitis A virus-induced pediatric acute liver failure, an etiology-specific study from the Department of Pediatric Hepatology, Institute of Liver and Biliary Sciences, New Delhi. I have no conflicts to disclose. Hepatitis A is a bane for the developing world. We previously published our experience with pediatric acute liver failure and showed that hepatitis A is the single largest etiology of PALF with significantly high mortality. Similar results have been shown from other centers over India as compared to the West, where hepatitis A is very uncommon. The general perception that hepatitis A cannot cause severe liver disease is flawed, as evidenced by death or need for transplant in as many as 24 to 69% of patients. The search for an ideal prognostic model is ever elusive. An ideal prognostic model should not only identify patients who are likely to die and list them for transplant, but also identify patients who are going to survive with their native liver to avoid unnecessary liver transplantation in them. The present prognostic models have been derived from a mixed bag of many different etiologies of PALF and may not be valid for a single specific etiology. For example, the currently used King's College criteria, which is most commonly used for listing of liver transplantation, requires 3 out of 5 of these following criteria. However, 2 out of these criteria, namely the age less than 10 years and presence of non-A hepatitis, is not present in most of the children with hepatitis A. Hence, many patients with poor outcome who do not meet this criteria do not get listed for transplant. Similarly, other prognostic models are also not HIV specific. Only recently our adult counterparts have recognized this fact, and they have devised this score known as the alpha score, which is a complex software-based equation of all these parameters. We hence realize the lack of data in children regarding the predictors of outcome in HIV-related acute liver failure and the dire need of a HIV-specific prognostic model. Hence, our objective was to study the predictors of outcome and to develop a HIV-specific prognostic model. We diagnosed pediatric acute liver failure using the PAL study group criteria. Hepatitis A was diagnosed using the anti-HIV IgM serology. Patients with incomplete records or unknown outcome were excluded. Institutional ethical committee approval was taken, and the outcome was decided at day 28. We used appropriate statistical analysis. We used logistic regression analysis to identify the predictive factors for poor outcome, and these factors were then used to derive a prognostic model. Coming to the results. As seen in this chart, out of our large number of 210 patients with pediatric acute liver failure, hepatitis A contributed to 47% of all other causes. This group of patients had a median age of 9 years, predominantly boys, with a jaundice to encephalopathy interval of 3 days, and 63% patients having presence of grade 3 or 4 hepatic encephalopathy, requiring intensive care for mechanical ventilation. Out of the 99 patients, 59 survived with their native liver, 31 died, and 9 were successfully transplanted. Now, coming to the predictors of outcome in HIV-related pediatric acute liver failure. We found that the patients who died or underwent liver transplantation were significantly younger, with longer jaundice to encephalopathy interval, and a large proportion of patients having grade 3 or 4 hepatic encephalopathy, requiring intensive care for mechanical ventilation, as compared to those who survive with their native liver. The patients with poor outcome also had a significantly higher bilirubin, INR, lactate, and ammonia, with a lower ALT and albumin. We tried to develop a simple, easy, and a bedside prognostic tool. First, we entered all these variables that were found to be significant on the univariate analysis into the logistic regression model and found that 3 parameters, namely the INR and jaundice to encephalopathy interval and the presence of grade 3 or 4 hepatic encephalopathy, were independent predictors of outcome. We then used the ROC curves to identify the best cutoff for the INR and the jaundice to encephalopathy interval, and we found that the best cutoffs for INR was more than 3.1 and jaundice to encephalopathy interval of more than 6 days, the predictors of poor outcome. So this was our final HIV-specific prognostic model based on the 3 significant criteria. The score can vary from a minimum of 0 to a maximum of 3. On Kaplan-Meier analysis, a score of 2 or 3 predicted significantly poor survival of 41% and 5% respectively. Hence, the presence of 2 or more variables was taken as the listing criteria of the PEDS HIV model. This PEDS HIV model, as indicated by the red line, had the best area under the ROC curve, with a sensitivity of 85% and a specificity of 83%, compared to the King's College criteria, which has a low sensitivity of 60%, and the PEL model, which has a low specificity of 61%. Now that we had baseline listing criteria, the next important step was to identify whether this model worked dynamically. What we found was that this model worked very well dynamically, with increasing sensitivity and specificity and diagnostic accuracy till day 7. These are the characteristics of an ideal prognostic model in pediatric acute liver failure. And our model ticks almost all of these boxes. The strength of our study was that this was the largest etiology-specific data on hepatitis A-related pediatric acute liver failure. For the first time, we have developed an etiology-specific prognostic model in hepatitis A-related pediatric acute liver failure. However, this study was from a single center, and we wish to externally validate our data soon. So I would end by concluding that the factors predicting the poor outcome in hepatitis A-related pediatric acute liver failure were presence of jaundice to encephalopathy interval of more than 6 days, an INR of more than 3.1, and a presence of grade 3 or 4 hepatic encephalopathy. Our PEDS HIV model was the best etiology-specific prognostic model. Thank you.
Thank you. I'm sorry, it's a nicely conducted study, and both the judges are pleased to see the institutional and ethical committee approval that you have got from your center. The question is, how different do you think this is to the King's College model? Yes, the 2 criteria, non-HA and non-hepatitis A to E criteria are not there in the age, but otherwise it's no different, isn't it?
So this model mainly has, as compared to various studies that have tested the King's College criteria, it has a significantly lower sensitivity, that is a higher number of false negatives. Firstly, because they have excluded patients with hepatitis A, which are predominantly our etiology. So a large number of patients we are trying to, we list them using the King's College criteria, they are not listed for transplantation, probably because thinking that hepatitis A will spontaneously resolve or they have a better outcome. So we don't have the prognostic model for this because of that one criteria. Secondly, even the age, that less than 10 years, hepatitis A is in our cohort as well as what is known, hepatitis A is mostly present in less than 10 years of children. That also gets excluded.
So I am quite impressed. I think the 3 golden questions in my mind always when I'm judging a study. First, is the question relevant and how are you asking it? Is that the need of the place? So there you definitely score very high. We don't see hepatitis A, but yes, in India you do have it. Second was the question done in a rightful manner in a scientifically robust methodology. And there again, I think you are pretty good. But where do you want to go with this? Because that's the third question. Is this going to be enforced in your center? Are you trying to go for multi-center for more validation? So tell me what the future holds.
Yes, sir. We want to externally validate this data because our being a center who has the facilities of liver transplantation, we have more sicker patients. Whereas we want to validate our data externally where more relatively less sicker patients come where the options of transplant are not available, which will give more accuracy to this model.
I just wanted to I'm so sorry, I'm just an OCD in certain aspects, but the sticking point over here is that those King's College criteria have been laid down for the NHSBT to decide about the urgency of transplantation. But still, it should not override your clinical concern for the child and the underlying diagnosis, So we are able to override that criteria if in children with hepatitis A. Okay, so I think that's one thing I would like to mention. Sir. I still want to congratulate you on doing such an extensive study and also on the conclusions, and it will aid bedside people. But I think I would suggest that you should present this in the IAP probably so that more general pediatricians are aware about it, so that they can refer patients earlier to you, and actually patients may benefit from this. Okay, thank you.
Thank you.